We also wanted to, as we shared in the earlier presentation or the video, it talked a lot about our crisis that we went through in 2008, 2009. And during that time, we had 36 deaths within an 18-month period within our community of Eskasoni. We had 9 suicides and several infant deaths and several related to medical conditions. So it was a very difficult, devastating time for our community. We were all impacted emotionally, physically, and economically. And Daphne probably can share a little story about that later. But so we needed to act, and Daphne's going to talk about that.
I mean, I can't imagine. I mean, 36 deaths in 18 months in any community, but in a community that is small and that is as closely knit as Eskasoni is, I can't even imagine the challenges and the impact that would have. And so I know that was one of the impetus that in 2010, in particular, the community really got together to make some changes, and particularly with the work that you're doing. So Daphne, can you tell us more about the changes that took place and sort of what was hinted at in the video?
One of the first things that we instituted when the crisis was going on, as you can imagine, 36 deaths in a small community. Most of us live in small communities here in Cape Breton. If you're not from Louisbourg, you're from, Reserve, or you're from New Waterford or North Sydney. Small communities, 36 deaths in a small community in a short period of time, it can be overwhelming and devastating. And Eskasoni was no exception to that rule. So what ended up happening was, through government partnerships when it was a crisis, the federal, provincial, and the community came together and established, with some funding, a 24-hour, 7-day crisis line. And it wasn't just a crisis line. It was in-person, online, so it's on Facebook. At the time it was on MSN. We've now evolved into Twitter and, anything, WhatsApp. We use messaging with clients. We use BlackBerry Message, anything that we possibly can. So we've evolved since 2010 into being available on every type of social media that we possibly can. So the crisis line was probably the first step in being able to ensure that we were available to people in need whenever they want it. From the first time the phone lines became operational, again, we were only supposed to be providing crisis intervention and referral services to the community of Eskasoni. But as soon as we went hot online, as soon as the telephone lines became active, we were getting phone calls from all of Unama'ki or all of Cape Breton. As time went on and the success of the interventions of the workers went on, we were getting calls from as far away as Montreal, Newfoundland, New Brunswick. There were a lot of people who were formerly from Unama'ki communities who had moved away and were working out west. And so it evolved from being a crisis line, and it still stands as a crisis line or a crisis and referral center. But people who were away, who had moved home, but wanted to stay away to work, would end up calling the line to speak Mi'kmaq to some of the workers. And for them, it alleviated homesickness. And they were able to stay away and work, earning money for their families, but they were able to connect with home. So it became a lifeline, a homesick line, a distress line, just somewhere to keep a little piece of home, even if you were in Alberta, even if you were out west. And so it's a little bit of a different kind of a crisis line, because it's not all about being suicidal, about being able to communicate with home.
But it is a distress line, and there are more issues than suicide in our community. Mm-hmm. There are marital disputes, there's family violence, there's addictions, and so by having the line available within the community allowed not just those who were depressed to call. It was an outlet for everyone, anyone that was having any issues, you know, family issues or personal issues. They could contact and they could connect with our workers. And the important thing was that because in Eskasoni is a very fluent community, and the need to, you know, as you all know, as healthcare providers or when you are in distress, when you are in upset, you go back to your first language. And so this was a service that was not being met through our provincial services. You know, we have a provincial crisis line, but unfortunately you can access every other language except Mi'kmaq language. And Eskasoni is very unique in that ability to be able to provide that service for, we provided it for all Atlantic Canada, wherever the Mi'kmaq people were. We were able to provide that service.
Mm-hmm. And in the context of that, we started off being funded by the federal government and the provincial government. And then as the years went on and there were no suicides or fewer suicides,
we weren't making the headlines any longer. So,
and that's a common theme that we'll revisit time and time again. When a community is not necessarily in crisis, that's when the funding slips away. One of the other things that we did at the time, we caught our breath, was we took a good hard look at the way we were operating. If you're familiar with funding, or if you're not familiar with funding in First Nations communities, oftentimes it comes down in very narrow streams or silos, and what it wants to do is work in isolation, because there's a funding pot for this. I call it flavor of the month or flavor of the year funding. Whatever particular topic strikes the interest of government. I'm never going to get into the Senate now.
This is where you announce your political bid. Surprise!
It's political, you know, favorite funding. That's the money that comes down, and it only stays around for 2 or 3 or 4 years. Rarely is it for 5. So what it forces everything to do in the communities is work in isolation. And what we decided back then was that isolation, that fragmented care was causing people to slip through the cracks. And the cracks in the community were literal cracks. They were grave sites. Young people were dying. So we had to take a good hard look. Well, is that working? No, it's not working. We're so fragmented. The left doesn't know what the right's doing. People are waiting an inordinate period of time to get care. So we struck a bold move. And against, you know, the funding initiatives, we threw all of the mental health programs together for one department, one umbrella, so that we all had to work together. We forced everybody together into the same location. And within, I would say, 2 months, although it was a difficult time, within those...
Change is extremely difficult.
Type of change you were making.
Yes,
hadn't been done before.
Hadn't been done before.
Yeah.
It was difficult, but within 2 months, and I give credit to the staff, because despite the fact that it was all really difficult, and up until that point we were all fighting for the almighty nickel, because we were all fighting for the same pot. When we were all thrust together, within 2 months, the staff realized, whoa, we are way better together than we ever were apart, because everything was streamlined. Everything was smooth. There were very, very few kinks in the system that a client could slip through. And one of the things that we did was we looked at what the spectrum of services were, what needs to be in a really good mental health service delivery model in a community.
And we brought service providers together. We brought all of the service providers that were currently working in the community from, within all of the mental health departments, addictions, anyone, I think we included the district, I'm not even sure. But anyway, I don't think we did, no, sorry. But it was primarily a focus of all the service providers who were currently services in the community, brought everyone together, talked about how we could move toward amalgamation, what were the goals, what were the strategies, and had developed a plan. And implementing the plan was the challenge. But over time.
Yeah, and the focus was prevention, health promotion, intervention, aftercare, follow-up. Because if you're in the mental health system, oftentimes, if you're in the formal mental health system, oftentimes the intent is to get you in, have you there for a period of time, 16 weeks, 18 sessions, and then you're out the door. Well, if you have a serious mental illness, our view is that we're probably going to be seeing you throughout your lifetime. And then we want to see you throughout your lifetime. If you need us and things are not going so good, be able to come into our office. When things are going good, your meds are working, your therapy's working, your coping skills are working, we want you to come in. We want you to share that with us. Because in the world of social work and psychology, those moments are few and far between sometimes. But we want to share those good moments with you. We want clients to come back when things are not going well. Just like everything in your life. When you're growing up, as you go through adulthood, there are highs and there are lows. We want our agency to be seen by the community as we want to be there when you're doing awesome, and we want to be there for you when things are not going well. So it's a big safety net to have. And we don't expect you to be in and out in 16 sessions or 18 sessions. We want you to be able to come back throughout your lifespan to share good news as well as when things are not going bad or not going well. We also we set up teams. So we had existing, before the amalgamation, we had case management, which is a unique case management First Nations model. Case management in the medical model is typically that two professionals would meet and discuss a client's case. In our, the client is the center. The client is the one who we involve as much as possible. It is their life. It's not my life, it's their life. They get to choose who they want involved in their care team. They get to choose what they think they can do or reasonably do to be successful. And we work on that with them. One of the things that we want to do in that process is ensure a fairly quick success rate for the client, because case management clients are typically the high risk, high user clients within the system. They've been involved with the judicial system, they've often had trouble with school or out of school, they have mental health issues.
Child and Family Services.
Child and Family Services have been involved. They've burnt a lot of bridges. So it's all about being able to bring them in, show them you can be successful despite your past, despite addictions, despite your involvement with the law. Every person in this room and in the entire world has something that is good about them. And that's what we try to give our case management clients. We try to ensure that all that hope and all that hopelessness all the hopelessness that they have, that we try to give them back a kernel of, yeah, you're a good person. You're either good at art or you're good at something. And we try and capitalize on that within a short period of time. Success in case management for clients that have really been downtrodden by the system is really important. So that's one of the components that we initiated. We also had a mental health crew, but we split them. They were only focusing on adults. With 50% of the population in most First Nations communities under the age of 25, we really youth department. So instead of, what we did was we reprofiled some of the staff to move from their focus of adult interventions to youth interventions. So case management, adult, youth, and we looked at the crisis line was brought in with us. The crisis line was brought in with us. Then we created, within 2 days, wrote a proposal and got funding for a residential school survivor team to be able to look at the broader context of colonization, residential school impacts, and being able to address the needs of school survivors. The next thing that we did was got all of the agencies that were involved within the community with youth together and looked at what are the services you're providing, what are the services you're providing, and tried to streamline some of that. Some of us were providing the same kinds of services, and clients were getting confused and whatnot, or we might be putting on activities the same night and trying to capture the same people. So we started looking at, let's organize ourselves so that we're putting on activities on a regular basis that meet the needs of the clients and the community members, but also that they're spread out, because we want to make sure that people know there are things going on, something to look forward to, and expand upon those and make sure that there was always something going on that people could be involved with. One of the key turning points for us was the life. We were asked to help the
Indian Brook?
Yeah, Indian Brook with putting on a suicide walk of life. And we thought it was going to be a somber event. And much to our surprise, and thank God for BlackBerries and social media, we thought it was going to be a somber event with maybe about 50 people attending. As people started walking throughout the community, it went from a small group of people to more than 500 people as they walked throughout the community. And it wasn't a somber event. It was uplifting. It was celebrating life. And thank God for BlackBerries, because we had only prepared food for 50 people. So we're messaging ahead to some of the ones further up in the community to ensure, and every pizza spot in Eskasoni was in full tilt making pizzas and stuff to ensure there was enough food. Arrived. And the event was absolutely stunning. So we went from thinking it was going to be a somber event to something that ended up being a celebration of life. Afterwards, when we had a chance to sit down and think about it, it was like, whoa, community's telling us something. Like, they're telling us they need to move forward. They need to turn the page on what's happened over the last 2 or 3 years. So it's about being in tune with your community and being able to hear what people are saying, whether they're actually saying it or they're doing it in. So we sat down and we thought, okay, that was in October. We thought, okay, how can we capitalize on this? How can we keep that good feeling going? And we worked as a community of interagency groups, so we came up with the idea of an event to occur in January, which was when a lot of the suicides had happened. And we called it Our Eskasoni, Our Celebration, Our Hope. And it was quite an ambitious celebration. We had planned on inviting everybody and having a feast to celebrate everything from soup to nuts. So there was artwork, there was dance, there was song, there was music.
It was just an opportunity for the whole community to share, to come together, to be part of a positive, celebratory event that brought hope and happiness to everyone in the community, on how wonderful it is to see the young children dancing, or the school band playing, or anything, just celebrating everything that was going on within the community. And it ended up, our first event, we had approximately 1,500 people show up at the event. And it was a stunning, we have lots of pictures, but unfortunately we can't share those pictures with you today, but it was a truly amazing event.